All right, everyone. So for your next in-service training module, we're going to talk about tachycardia management. You will see, if you've looked at the protocols, that we have a few more tools in the toolbox for managing tachycardias. So these are our objectives. So we're going to review common tachyarrhythmias and how to classify them. We're going to talk about antiarrhythmic drug classifications. We'll talk about the indications and contraindications of common antidysrhythmics, and we'll talk about how to appropriately treat patients and match the treatment with the EKG characteristics. And we'll talk about the management of stable and unstable patients and what that means. So this is a highly contentious topic, unstable versus symptomatic. So generally, unstable refers to a condition in which vital organ function is acutely impaired or cardiac arrest is ongoing or imminent. So an unstable patient is someone that you think is going to arrest. Symptomatic is a patient who's having an arrhythmia that's causing symptoms, but there is more time available to decide on the most appropriate treatment. And this is directly from the AHA. They say that in both unstable and symptomatic cases, the provider must make an assessment as to whether it is the arrhythmia that is causing the patient to be unstable or symptomatic. So you have to decide if it's the arrhythmia that is causing the patient to be unstable or symptomatic. This is very important when we talk about AFib, because often patients that have underlying AFib can have AFib RVR and appear unstable, but the AFib RVR is actually compensating and not causing their instability. The HA goes on to say that if bradycardia produces signs and symptoms of instability, so if they have an acutely altered mental status or ischemic chest discomfort or acute heart failure, the initial treatment is atropine. Then they say if that bradycardic rhythm is unresponsive to atropine, then some type of rate accelerating beta adrenergic agonist is indicated. So that's either dopamine or epi or pacing. If it's unstable, you know the treatment for that. So if they're peri-arrest, then you need immediate cardioversion or immediate pacing. If they're tachycardic, or if they're bradycardic, pacing. If they're tachycardic, synchronized cardioversion. Then they say in select cases of regular narrow complex, not wide complex, tachycardia with unstable signs or symptoms, a trial of adenosine before cardioversion is reasonable to consider. Now, I would have a very high threshold to cardiovert someone with, quote, SVT before I tried adenosine. All right, this is a general breakdown of the antiarrhythmic medications that we will be carrying on the ambulance very soon. So adenosine, you should be very familiar with that. So it slows or blocks conduction through the AV node. You know the dose, it's 6 and 12, used to be 6, 12, and 12, no longer that extra 12. It can cause bronchospasms, so you would want to avoid it in patients with bronchospastic type diseases, and it's contraindicated in asthma and AFib with WPW. You'll see this a lot. Any medication that slows conduction or blocks conduction through the AV node is contraindicated if the patient has AFib with WPW. Cardizem, so that is a calcium channel blocker, so it slows AV nodal conduction, increases AV node refractoriness, so the cardiac conduction system is going to be more refractory to further impulses. The indication for that is stable narrow complex tachycardias. And from the HA, they say if no change with adenosine. Now, clearly, that is for regular complex tachycardias. And then it is to control ventricular rate in patients with AFib or atrial flutter. Now, we don't have it listed. We don't have cardizem listed as an to be used in stable, narrow, regular complex tachycardia, just atrial fib. This is the dose, and that is also same dose as the protocols, I'm pretty sure. But it's generally around 15 to 20 milligrams, and you truly do want to give it over 2 minutes because cardizem can cause hypotension, bradycardia. You can give another dose in about 15 minutes. You're going to increase that by 0.10 mg per kg, which generally ends up being around 20 to 25 in about 15 minutes. Again, only give to narrow complex tachycardias. If you give this to a patient with a wide complex tachycardia and it ends up being ventricular tachycardia, then they will rapidly decompensate and arrest. I don't think I need to repeat that again, but you also want to avoid it in ventricular tachycardia, or you want to not use it in AFib with WPW. Amiodarone is a class everything blocker. So it does all of these things. We give it to regular wide complex tachycardias, and it's 150 milligrams given over 10 minutes. 150 milligrams given over 10 minutes. It can cause bradycardia, hypotension. There is not a direct contraindication, but you still want to avoid giving it in AFib with WPW. Why? Because it can still block conduction through the AV node. Magnesium. So magnesium is kind of a complicated drug. It's a lot of people have trouble describing the characteristics or effects that it has, but the indication is polymorphic VTAC associated with QT prolongation. You know this as torsades. And what is the difference between torsades and polymorphic VTAC? I think we're going to talk about that. So the dose is 2 grams IV over 10 to 15 minutes. So it can cause hypotension, CNS toxicity, respiratory depression. So all of these drugs can cause hypotension. So what kind of patient would you not want to give it to? A patient with hypotension. There are a lot of different classifications of tachyarrhythmias. So we're not going to go into great detail on all of these, but needless to say, there they all are. The most common tachyarrhythmia is sinus tachycardia. Okay, so is this really sinus tach? What do you think? Well, if you said yes, you would be correct. It is sort of subtle, but there are actually P waves, and the best lead to look at P waves is V1, and you do see P waves in V1. In the other leads, often the P wave is kind of buried in the T wave of the preceding complex here. Okay, so you get like this double humped looking T wave. That's actually a P wave, and the treatment for that is, of course, treat the underlying cause. There you go. Atrial fib. So the main characteristic of atrial fib is that it is irregularly irregular. Now, if you had atrial fib at a rate of, say, 40, QRS rate was 40, and you had little fibrillatory waves like you see in V1. Now, let's say that it was perfectly regular. Can AFib be perfectly regular? The answer is yes, if the patient has a third-degree heart block. The treatment for AFib, RVR, is first to consider the underlying cause, because a patient with AFib can't have sinus tachycardia. So what do? They go into AFib with a rapid rate. And again, that is the treatment. So if the patient's older than 65, you might want to give a lower dose. Atrial flutter. So you might look at this and say, well, I don't really see flutter waves. That's because this is 2 to 1 atrial flutter. And if you see here, you've got 2 P waves for every QRS. Okay. There's actually one right there in the T wave of the previous complex. So 2. So if the ventricular, or if the atrial rate is 300, and there's 2 P waves for every QRS, then what do you think the ventricular rate is? Well, it would be 150. So anytime you have a patient with a rate of 150 plus or minus 10, you should always think atrial flutter. If it is pinned on 150 or 149 or 151, give or take a few beats, and it doesn't move, you need to be thinking atrial flutter, 2-to-1 atrial flutter, because it is very common. Now, the best way to decide if it's really atrial flutter, well, there's a few different tips and tricks for this, but if you use your imagination and look in the inferior lead and you imagine that the QRS complex was not there, then you can see the sawtooth pattern. But also, frequently, you will see little breaks. So the R to R intervals for all of these are pretty regular, okay? But you will see at some point there's an R to R interval that is a little longer. So there's a pause, okay? So this is actually 3-to-1. It's still atrial flutter, but with 3-to-1 conduction. If you look here, you see 3 P waves. Treatment for that, same as treatment for AFib, if you even need a treatment, if you even need to treat it. So AV nodal reentry. What the heck is AV nodal reentry? Well, that's what you usually refer to as SVT. But SVT is an umbrella term. It encompasses a lot of tachyarrhythmias. Technically, if it's a tachyarrhythmia that originates from above the level of the AV node, then it is a supraventricular tachycardia. It's SVT. Technically, sinus tach is an SVT. But AV nodal reentry is what we think of when we're saying SVT. So this is a very fast, regular, narrow complex tachycardia. Now this rate is right at 150. You can see, so from a thick black line to a thick black line is 300. Then from a thick black line, skip one to the next one, is 150. So this rate is right around 150. All right, you see no evidence of P waves, no flutter waves. So where is the P wave if this is a supraventricular tachycardia? So there are some different pathways. This is a reentrant pathway. And in patients with SVT, they have 2 different pathways. They have a fast pathway. So the impulse comes down from the SA node from the atria, and it doesn't usually go down both pathways, or it only goes down one pathway because the other pathway is refractory, right? Because it has a longer refractory period. It takes it longer to repolarize, okay? So conduction from here down is blocked from going back up. But if you have a properly timed premature atrial beat, then it will enter, this limb, so the fast pathway will be refractory, so it'll have to go down the slow pathway, and when it does, as soon as it gets to the bottom, it finds this long pathway no longer refractory, or it's completely repolarized. So then it enters into a loop. When it enters into that loop, it can send retrograde impulses from the AV node back up into the atria. And then it sends anterograde impulses down into the bundle of His and Purkinje fibers to the ventricles. So you still get a narrow complex tachycardia, but you don't get any P waves frequently because they're conducted retrogradely and they're hidden in the QRS complex or immediately after it. So look here, you see, and depending on the pathway that it takes, whether it goes this way or goes this way, determines where you'll see the P waves, or if you see them at all. So the slow-fast pathway is the most common form, and we kind of describe the pathology of it, but the retrograde P wave is obscured in the corresponding QRS or occurs at the end of the QRS complex. Okay, so oftentimes it'll be right here, and it looks like a little tiny R wave coming back above the baseline. Okay, this isn't the best one, but it's the best one where you can actually see the P wave, but often you won't see a P wave at all. It will just be a fast, regular, narrow, complex tachycardia. What's the treatment for that? Well, of course, your standard Valsalva maneuvers, and if that doesn't work, you can try something new that's called the modified Valsalva maneuver, or revert. So how do you do that? We have the patient sitting up. You have them blow into a 10 cc syringe. Now, they probably won't actually be able to move this plunger, but you want them to try. You want them to say, I need to see you move this plunger. Blow, 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 blow. They blow on it for about 15 seconds. After 15 seconds, you lay them flat and you raise their legs up 45 degrees for about 15 seconds. This converts, supposedly converts, SVT or AVNRT more than the standard Valsalva maneuver, and possibly more than adenosine. So it's definitely worth trying, as long as the patient is able to do it. Ventricular tachycardia. So why is this ventricular tachycardia? Well, it's ventricular tachycardia because it's wide. You'll actually see it's very wide. So the QRS is almost one big block. Remember, we said in another video that if it's more than one big block, you need to be thinking tox or metabolic, okay? And this is really close, but it's really wide, really fast, and it's really regular. So when in doubt, wide, regular, complex tachycardias are ventricular tachycardia until proven otherwise, and treat them accordingly. If it is not ventricular tachycardia, and you treat it as you would ventricular tachycardia, then you're not really going to hurt the patient. But if it is ventricular tachycardia, and you treat it as if it's not, i.e. you try to give cardizem, then you could significantly cause harm to the patient. So wide, fast, and regular equals ventricular tachycardia every time. What's the treatment? So if they're unstable, then you can synchronize cardiovert them. Preferably you would sedate them first. If they're stable, you can try adenosine first. The H8 says you can try adenosine first. They also say that adenosine could be potentially diagnostic. So they say that if you give adenosine and they convert, then it was SVT with aberrancy. So, which means that if the patient had an underlying right bundle or left bundle, they say that you can that can be diagnostic of SVT with aberrancy. But there is some forms of ventricular tachycardia that will convert with adenosine. All right, so but it also could be SVT with aberrancy. So it doesn't hurt if the patient's stable to try adenosine, but the treatment is 150 of amio over 10 minutes. So you put 150 milligrams in a 100 cc bag, and we're getting 100 cc bags, and using a 10 drop set, you would deliver 100 drops a minute. 150 milligrams of amio, and this is the same thing with anything that you want to deliver over 10 minutes. You take the dose, you put it in a 100 ml bag, and if 10 drops is 1 ml, you need to give 10 mLs a minute, because 10 times 10 is 100, and you're given 100 mLs. So you would give around 100 drops, because 100 divided by 10 is 10. Okay? Pre-excited tachycardias. So what are we talking about when we say pre-excited? We're talking about WPW. So patients with an accessory pathway. Generally, generally it comes down from the SA node to the AV node, and it travels through the bundle of His to the right and left bundle branches, and then the Purkinje fibers. But in WPW, they have an extra pathway. Now, this pathway can be anywhere. It doesn't have to be here. But so it would come down, conduct anterogradely, so down the normal conduction pathway, and then come back up through the accessory pathway. So you see the normal pathway. What you get on the EKG is a short PR interval in this delta wave. So what is this delta wave? Well, it is a fusion beat between the normal conduction pathway, so it can conduct down the normal conduction, and then it can also travel through the accessory pathway. This is what you will see at their baseline. If the patient has WPW, a reentrant type WPW like this, if it just keeps re-entering, then then you're not going to see that delta wave because the impulses are not fusing together. Okay, and the reason that you have a short PR interval is because of that delta wave. If that delta wave was not present, then you wouldn't have a short PR. So here's generally what it looks like. And you can see that you have ST abnormalities as a natural occurrence, because anytime you have abnormal depolarization, you have abnormal repolarization. Think left bundle or LVH. So what is wrong with this patient? Well, this ended up being WPW, but they didn't know that at the time. What is wrong with this patient? This was also WPW, but it looks like a regular, pretty wide complex tachycardia. Now, the typical treatment, if it is a regular wide complex tachycardia, and you don't know if they have WPW or not because you won't when they're tachycardic, then the typical treatment that you use for VTAC or even SVT is fine, because the impulses are re-entering either this way or they're re-entering this way. And if you block the AV node, then you're going to terminate that abnormal rhythm. But if they have this rhythm, if they have AFib with WPW, which has a characteristic morphology, it's very fast, it's very irregular, and the shape of the QRS complexes change in size and amplitude, and this is probably better. Also see that the ventricular rate is conducting about 300 times a minute. All right. Normally in SVT, or physiologically, the rate can't go that fast unless there's an accessory pathway. So if you see a rate approaching 300 a minute and you see this wide, irregular morphology with changing shape, amplitude, then that is AFib with WPW. And you do not want to you do not want to administer adenosine, you don't want to administer calcium, or cardizem, you don't want to administer amiodarone, because if you block the AV node, let's say that you've got, so what's happening is you have the atria is firing randomly, okay? And the atrial rate is somewhere around at least 300 a minute, okay, in AFib. If you block this AV node, what happens? Well, think about what the AV node normally does. Normally, if the atrial rate is going about 300 a minute, why is it that the ventricular rate can't normally conduct 300 a minute? It's because that the AV node slows conduction, right? The AV node slows conduction. And why does it slow conduction? Well, it slows conduction to allow ventricular filling, all right? Now, what happens if you block the AV node and the patient has AFib with WPW? They have this accessory pathway. This accessory pathway does not have the protective properties that the AV node has. So all of these 300 plus impulses can travel unimpeded through the accessory pathway and cause the patient to go into VF and arrest. So do not administer AV nodal blocking agents to those patients. So how do you treat it? How do you treat this? The safest thing to do is sedate and cardiovert, period. Procainamide is an option, but we don't carry procainamide. Now, what's the difference between torsades and polymorphic VTAC? So take a look at this rhythm. Would you call this torsades or polymorphic VTAC? If you said torsades, you'd be wrong. If you said polymorphic VTAC, you'd probably also be wrong, because the answer is we don't know. If you have this patient with, well, I'll just ask you, what are the abnormalities that you see in this EKG. I'll give you a second to mull over it here. There's a first degree AV block, but look at these T waves. They're biphasic. Okay? What is this extra blip right here, right before the P wave? Well, that's a U wave. And what causes a U wave? Well, it's generally hypokalemia. Now, some patients can have U waves at baseline, but it's not very common, especially in the older population. So would you say this QT interval is prolonged? Or would you say you don't know? You can look at the QTC here, and a QTC of 460 is borderline prolonged, but is that accurate? I would posit that it's not accurate. The best way to determine if the patient has a prolonged QT interval is to, say, draw a line at the end of the T wave, or in this case it'd be a TU wave, and say, is it longer, or actually you draw a line immediately between the R to R intervals, so somewhere right in the middle, which would be about right here. And if the T or TU wave is longer than half of the R to R interval, then it is a prolonged QT interval. And that's a good little trick to help you quickly determine if the patient has a prolonged QT interval. Now let's see if I can get this to play. I may have to exit out of it here. This was an actual case that somebody had. Same patient from the previous 12 lead that I showed you. PVC, 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 and then you can see that this is clearly torsades. Now, why is it torsades? It's torsades because the patient had an underlying prolonged QT interval. If you don't know if the patient had an underlying prolonged QT interval, then it's safe to call it polymorphic VTAC or just polymorphic VTAC. Now, a lot of times you won't know because you'll get to the patient and they'll be in torsades. Now, is torsades a rhythm that a patient can remain conscious with? The answer is yes, at least for a short period of time. And if you don't treat them, then they can go unconscious rather quickly. So how do you manage torsades? Well, if they're unstable, or if they're peri-rest, or if they're in arrest and you see torsades, then the treatment is clearly defibrillation. Then you can consider a few grams of MAG over 10 minutes. How do we deliver it over 10 minutes? Well, you put in a 100 ml bag and you use a 10 drop set. 10 drops is 1 ml. And then if you want to give 100 mLs a minute in order to give, if you want to give 10 mLs over a minute in order to give 100 in 10 minutes, then you need to give 100 drops a minute. If you don't know if the QT is prolonged, then it's also reasonable to administer amiodarone. Accelerated idioventricular. So what makes this accelerated idioventricular? Well, technically this is accelerated idioventricular with some capture beats because the underlying supraventricular rhythm or P waves are actually capture, okay? But this is actually accelerated idioventricular with capture beats. This is also accelerated idioventricular, but I don't see any clear capture beats. You can see a P wave here that is dissociated because the impulse is actually coming from the ventricles, right? So this is a ventricular rhythm. You can also see a P wave here. And if you search throughout the EKG, you could probably identify other P waves. But this is also accelerated idioventricular. So how do you treat that? Well, you generally do nothing, okay? It is commonly a reperfusion rhythm. So if you get a pulse back, the patient may be in accelerated idioventricular. And if the patient's having a STEMI and they spontaneously reperfuse, so if the coronary artery is occluded and then it reperfuses, they frequently go into accelerated idioventricular. Now, if the impulse is coming from the ventricles, why would we give medications that would take that impulse away? So the treatment is nothing unless the patient is unstable, and then the treatment is either pacing or beta agonists like epi or dopamine to increase the rate. So in summary, some patients can be stable for long periods of time with any tachycardia, while others may decompensate quickly. You need to always prepare for patients with tachyarrhythmias to decompensate. So apply pads early. So if you've got a STEMI patient, just put the pads on. If you've got a patient with any tachycardia, put the pads on, because you never know what could happen. If you're ever in doubt of if you should cardiovert or if you should try to cardiovert with medications, then electricity is always the safest option. All right. So beware of very fast, wide, and irregular tachycardias, because you should avoid AV nodal blocking agents. Remember, fast, wide, and irregular, avoid AV nodal blocking agents. For sinus tach, AFib, RVR, consider the rate being compensatory first. If the patient has a possible underlying illness that is causing them to compensate, then think of it primarily a compensatory rhythm as opposed to a rhythm problem that caused their symptoms. And again, AIVR rarely requires treatment. Okay, so I hope that if you have any questions, feel free to email me or call me. And I hope that you enjoyed this, and I hope that you enjoy all of these modules that we're doing to in-service our new protocols.